the session over to Dr. Mark Shapiro, who is the Group Medical Director for Dream Team and Vice President of Clinical Strategy and Innovation. Mark, it's all yours.
All right, well, Marty, thanks very much. Obviously, I agree with everything you said, and let me just welcome everybody. Thank you for taking your time to participate with us. I hope you're going to find it engaging, and I hope you're going to find it thought-provoking, and even more than that, I hope it's going to help you to take better care of your patients moving forward. So tonight we're going to talk about converting in-center hemodialysis patients to one of the two forms of home dialysis. I think having a really functional process to do this is profoundly important because, well, let's just go to the next slide. Yeah, so we have all kinds of data like this that make it clear that a majority of patients that start dialysis in the United States do not start with a well-planned way that we would like, right? I think we have to just accept the fact that in many cases, patients land in our in-center clinics not because they've made thoughtful and intentional choices to do in-center chemo, but in fact because they have not made a choice, or in some cases may not have even been given a choice. And so when I go into my clinics, my intention is to think about each individual patient and try to identify what's going to be best for them. And I never assume that just because they're in the in-center dialysis clinic means that really is going to be the best choice for them. And so go to the next slide, please. And so I consider it my obligation as a clinician and as a patient advocate to try to figure out what's best for every individual patient. And I believe really firmly that we have four kinds of dialysis. We have home chemo, we have peritoneal, we also have in-center nocturnal, in addition to conventional in-center hemodialysis. I believe that we ought to be thinking about patient-centric care, and with every single one of our patients, trying to get them to that form of dialysis which is going to be best for them. With, like Marty said, different points of time, different situations might be that one type of dialysis might be better at a given time than a different type of dialysis. So let's go to the next slide, please. COVID has made this more difficult, right? Because some of the things that we've done traditionally, either to get people onto PD or to convert them from in-center to PD, has made this more difficult, right? We know that most nephrology groups in the United States have essentially switched over to telehealth, very limited visits in the office. Patients haven't been getting labs. There's typically been a suspension of in-person CKD education. We know that in many cases, both placement of fistulas and PD catheters has been tremendously impaired because of COVID. And then we also have patients that have been really reluctant to go to the hospital for elective procedures. And we're going to see the consequences of this in June and July and August. Next slide. And so if you look at the VITA data, and I'm going to show you a couple of the VITA slides, just looking at what's really happened since the beginning of the year, I don't think it would come as a big surprise that we've seen a significant reduction in both new patients starting on PD, but also patients converting from in-center hemodialysis to PD. We all hope that this is a really temporary trend because we were seeing really nice growth in both of these areas up until February and March, but still these numbers are what they are. Next slide, please. But I think the other thing we have to recognize is this drop-off in patients to PD is not limited just to PD. This is also being seen very permanently across the country by in-center hemodialysis. And although we don't completely understand this data yet, we think we understand some of it. We know that patients are simply not seeing their nephrologist, they're not getting their lab, they're not getting their access in place, and they put off starting dialysis. And you can imagine if all these people really needed to start dialysis, but they haven't, we're going to see, I think, a tidal wave of patients landing in hospitals needing to start dialysis. And I asked all my colleagues, are we ready for this? Are nephrology groups ready and prepared to deal with this influx of patients? An increased number that are starting dialysis is not really ready to start dialysis. Next slide, please. And so one of the consequences of this is we're seeing, and this isn't just really in the month of March or April, but what we're seeing is a pretty steady increase in the rate of in-center hemodialysis catheters on the first day of dialysis. And I think we're going to see this go up in the month of June again. But The point I'm making, I suppose, is that now more than ever, nephrology groups need to be prepared to address their patients who are starting an in-center clinic and really reconsidering whether in-center hemodialysis is really the right place for them to be. Next slide. And so I will share with you that DaVita, and I'm sure all of the big dialysis providers have put enormous amounts of efforts and resources into responding to COVID, not just related to home dialysis, but in every way. And I just want to share with you that we are trying to get our traction back again. We are now allowing dedicated dialysis educators back into most clinics. We're also beginning a process of virtual patient education, which could be discussed a little bit more. There are other things that we're doing, right? We've been trying to work on key catheter placement process to make it a little bit easier for everybody. And recognizing the worries about COVID, we're arranging for testing before catheters are placed. And we're also arranging for testing before the patient initiates training. But the first line is we're doing what we can to respond to this, but it's going to take a little while, I think, for us to catch up. Next slide, please. And so with that, I'm going to ask you to listen for a few moments to a physician from the Bay Area of San Francisco, Dr. Aaliyah, who's got his own story to tell, and I hope you find this story really compelling. So I'm going to hand it over to you, sir.
Thank you very much, Mark. Yes, this is Aaliyah, and I think unlike the the expert home doctors that you've been listening to so far, I would call myself, I'm one of those regular nephrologists, right? So I've been private practice with 4 other nephrologists in San Francisco. I've been practicing with a nephrologist for 25 years and have 70+ dialysis patients. And out of those, I only have 2 home hemo and 4 peritoneal dialysis patients. And my old approach, I would say, old approach meaning until June 1, for the last 25 years, that when patients were seeing me in stage 4 CKD, I definitely encouraged home therapies, especially peritoneal dialysis. I wanted them to keep their independence. I referred them usually to Kidney Smart. And then when patients had just started hemodialysis and still perhaps don't have a fistula especially, I would use that other opportunity to kind of talk to them about home modalities. Now, I have to admit, for my established, stable, compliant, in-center hemodialysis patients, I make very little effort to switch from them. Said, if it's working, why change it? That's basically my approach. Now, what motivated me to change my approach? I've had several recent discussions with our regional directors from DaVita, and he kind of pointed out to me, said, Dr. Aaliyah, I just want to let you know that your percentage of home patients is only about 8%. And in the region, it's 15%. And my competitive spirit is, well, if somebody can do 15%, I should be at least able to do that. We're working in the same area. The other thing that really affected my thinking, which I thought was a potential change in how we look at this, is the coronavirus pandemic. Here we are trying to keep our highest risk patients at home, except for my in-center dialysis patients. We drag them 3 times a week to be exposed potentially to other people, and that was the other opening for me. Next slide, please. So my aha moment was thinking, if in-center dialysis is now more of a sinking ship, not that there's anything bad with it, but that it puts people at extra risk potentially going in and out because of the coronavirus pandemic, how many of the patients that I thought are stable on this ship can probably survive and do better even with home-based modalities? And this is different than the approach I've had before, which is more of the don't rock the boat. The other part of my motivation is I came up with the idea that if I'm going to do something different, if I'm going to speak to the in-center patients, if I'm going to talk to them about home modalities, I want to be able to keep track of my actions, keep track of when I talk to them, keep track of what happens to the referral to the peritoneal nurse or the home-based modalities, so that I know what I'm doing. I have so many patients to keep up with. The next slide, please. So at the end of one of our patient conference meetings. I said, why don't we take some time right now, since everyone is talking about, going to home, let's take some time now and just go through the list of patients. And I had about 25 patients in that center. And in the matter of 8 minutes, I went through 25 patients, and I gave everyone a green designation, yellow designation, or red designation. Green meaning they're a good candidate for peritoneal dialysis. Yellow, maybe a so-so candidate. There were just a couple of those. And red, were perhaps somebody who was at the end of their life or severely frail, and I thought maybe not the best person for a home-based modality. Now, to my surprise, out of the 25 long-term, stable, center hemodialysis patients, 18 out of these 25, I gave them the green light. So, next slide, please. And I started to speak to, I went that afternoon and I started speaking to my 4 shift patients over there. There were about a handful, and the next shift that I went to, and I said, let me just talk to them. And I spoke to the green patients about peritoneal dialysis or that home chemo that would have been part of the conversation. But I was focusing on sheltering in place and with a different, with a different thinking about it. I wasn't talking to them because they had failed their dialysis access. I didn't talk to them because they were gaining too much fluid necessary. I didn't talk to them because they were having a lot of problems with hemodialysis. I just talked to them about it because I wanted them to really consider this as a potentially even better option for them. And again, to my surprise, in this step 2, that 2/3 of the green patients that I spoke to that were on long-term and center dialysis, they actually wanted to know more about peritoneal dialysis and were willing to meet with a home dialysis educator. Next slide. So I wanted to keep track of my approach, and so I created a table, which I then sent to my facility administrator, Becca McKissick, and I asked Becca, is there a way we can make this into a form that is functional, that I could be able to share with you in a safe, HIPAA-compliant way that's encrypted? And, we came up with this sheet, basically. It's a table where I put in the patient's name, their green, yellow, or red designation, and the dates that I happened to speak with the patient. And then, the most important thing was that the patient interested in finding out more information or not. This encrypted, protected document is shared with our facility administrator, the social worker, the dietitian, the clinical nurse, as well as our local peritoneal and home modalities educators. And I was very excited with this because while I'm rounding one of the patients using my iPad and Falcon HR, I would just put the dates right there and a yes and a yes. I spoke to them and yes, they said they wanted to, no, they didn't want to. And in real time, the rest of my teammates knew exactly what was going on, and they just follow up with that and make the appropriate referral. And I appreciated being able to kind of have a list where I could check off, okay, I've spoken to half of them so far, and now what I have done. So, and I have to say, using this, I've spoken to at least about 14 patients so far, and at least half of them are already interested in finding out more, have already met with our home dialysis educators, and 4 of them in the last 48 hours are either on their way to getting home visits or have already made appointments with the peritoneal dialysis access surgeon. So that, I have to tell you, is more potential PD conversions. I was just telling Dr. Shapiro, more PD conversions potentially in the last 2 weeks than I've had in 10 or 15 years. And part of my excitement is having it there with me in my hand and having this new conversation to be able to have. I think just one more slide, I believe. So one of the ways that I think I might ask you for DaVita support for the conversion process, I believe some of this is underway. It's a conversion tracker like we're using right now that will be secure, that I can use for my patients and to be shared by the other teammates. And imagine a template in which, imagine your comprehensive notes that you do on a monthly basis, that there's a box that says you can check off that I discussed home modalities with the patient, that this would trigger an annual alarm. Doc, it's been a year since you talked to them. You need to talk to them now. It'll pop up when you talk to them. So real time while you're there with the patient. packet of all the patients who are interested in the home modalities that we could share with our home folks. The other thing that I know already exists, but is increasing the need, especially in this day and age, is having a broad range of videos from personal narratives from patients who have tried chemo, who tried peritoneal dialysis, who have tried home chemo, who can talk about their own experience, and to have people from speaking from multiple languages, multiple cultures, different age groups, speaking, that you can share this library of videos and customize it and send it to your patients so they have one of their peers discussing them. So that's what I have to share with you right now, and I'll be open for more discussions later on. I just will hand it over right now to Juan Ramos, who is our regional modality educator. Next, take us, Juan.
Thank you, Doctor. Good evening, everybody. My name is Juan Ramos. I am the regional modality educator for the Palm Springs and Temecula areas in Southern California. Next slide, please. I am not a doctor or a nurse. I am actually a former DaVita patient. Patient education was not a big focus when I was a patient, since in 2009. Luckily, DaVita has taken an initiative towards making sure every patient is educated on the different modalities offered, including PD, ICHD, care center, and external where available. There has been a creation of multiple step processes where patients receive education by various teammates, from administrative assistants to facility administrators. The process includes chairside education, one-on-one classes, and now virtual reality education. The patients are also assessed using the MATCHD tool. The MATCHD tool, similar to what the doctor was just speaking about, and are placed in one of three categories: strongly encouraged to home, encourage home after assessing barriers, and may not be a home candidate. Update assessments weekly on a virtual tracker, which can be located on a HIPAA-compliant website on the DaVita server and accessible via VPN. Nephrologists are encouraged to go over the MATCHD with their IDC, discuss patient status, and approve assessment and orders for the transition. Patients are able to move between categories depending on health, social, and mental improvement. This is vital. Once the patient has shown interest towards the home modality, the in-center team will reach out to the home program for a one-on-one education. A nurse, home team, or regional educator in your region if available will give the class. Next slide. Next slide, please. Okay, so sorry. You can go back higher. Each class and each conversation really needs to be tailored to the patient's understanding and emotional state. Each patient is unique. Educating the patient is not the lesson has to be the priority of anything. The class is focused on explaining the pros and cons of each modality and empowering patients to make a choice. Patients want to make their own decisions and feel control. When patients are proactive, this leads to better results and patient retention. Patients learn the medical aspects of home treatment during the training. I've come to realize that what the patients are looking for is what their day-to-day patients need to understand the commitment it will entail to train and dialyze during that period, the monthly visits, and the expectation that will be required from them. Numerous patients who returned in-center were not just to the dialysis part of the treatment. It was more that they still realized the responsibility of keeping records, adjusting prescriptions, and just keeping that communication with the nurse and lastly, making sure patients understand that the process towards any home modality will take time. There are steps that need to be followed after this decision. In many cases, taking weeks or months to get home. These will help the patient navigate the entire conversion process. Communication between the in-center team and the home program is critical. So both programs can have quickly and coordinated fashion. This may differ if you're planning to have an attached program or a standalone unit. Team maintains you, the nephrologist, involved during the entire process. There are cases where patients do not attend and show interest in home modality. MDs and teams of both programs will work to address any area. On the other hand, there are patients who deteriorated while in the process. MD and teams will work together, and finally, patient and MD will make the final decision. Next slide, please. There is quite an array of material and resources at its disposal. DaVita has different videos that are downloadable and available online, especially on YouTube. There are also pamphlets and discussed with the vaccine, patients change over time. Someone who might not have been a candidate at one point, at another time would be a great candidate. Something to keep in mind, not only does the patient change over time, but also the success in the therapy. If a patient has been non-compliant or unsuccessful on the therapy, MC and team do a deep dive on the patient. It might turn out that they will flourish on another modality. I cannot tell you how many times I see this occur with patients going home. Just because someone has been deemed not a candidate doesn't mean they will never be able to. Next slide. As you can see on this slide, conversion rates vary from region to region with DaVita. It seems obvious that some places have done a much better job than others at identifying appropriate patients for home modalities and helping them get transitions home. Nephrologists should know how well their clinics are performing in this area. This is why we hope you're involved in the PhD. Overall, education process continues. DaVita will continue developing different materials for these years. Just want patients to be able to receive that opportunity. And with that, next slide. Here's Dr. Curley.
Thank you so much, Juan, and it's a pleasure to be speaking to you today. I just in those statements that I'm just going to try and make it a little bit simple and give you perhaps a perspective from north of the border in Canada on some of the things that we've done that have been successful in transitioning a patient from in-center hemodialysis to a home modality. So I call these 6 steps for successful transition. We have to understand the patient population. We have to assess the readiness of the patient to change and really engage their circle of care. Facilitate a transitional care model, and we'll talk about that. And really, once we get them on a home modality, we have to send an initial prescription that considers lifestyle first. And then lastly, monitor residual kidney function and make analysis prescription changes slowly and thoughtfully. And 6 is to establish an open line of communication. And the reason why some of these focus not only on things that we can action before a patient converts to a home modality, but also once the patient is established, is because I think we would all want our patients to convert to home and be successful on home dialysis. And certainly we don't want to see our patients transition back to in-center hemodialysis in a short period of time. So it's really important to consider that early period when patients are converted to home as what I would call a very high-risk period and a period where we have to be really careful and support our patients. Next slide. And so understand the patient population. And so this is a slide that from a paper that we published a few years ago. And it compared the transition back to hemodialysis among 2 groups of patients. The first population of patients were those who started PD first and had not started on in-center hemodialysis. And the top bar were patients who converted to PD from in-center hemodialysis. And the patients who converted to PD from in-center hemodialysis experienced higher rates of technique failure necessitating a transfer back to hemodialysis compared to patients who started PD without any prior modality. And I've often wondered about this, and I think it's really important that we understand that these may be enriched with a group of patients who didn't have very much pre-dialysis education and sort of crash started or were discharged from hospital to an in-center hemo unit without much pre-dialysis education. They also might be a group of patients who experienced a more rapid decline in kidney function or more acute kidney injury. They also might be a group of patients who have seen in-center hemodialysis. And because they've been on in-center hemo before, it might be easier for them to hit the eject button and transfer back to PD to in-center hemo at the first sign of trouble. And so, yes, this is a very high-risk population for technique failure. But I also think that, and I'm going to be the first to admit this study is comparing the apples to oranges group of patients. And really what we ought to do is look at what would have happened to those patients were they to have stayed on in-center hemodialysis and not have the opportunity to go to PD. And I was at a PLS meeting several years ago, and I can't remember who it was, but it really stuck with me. And, you know, it said to me, like, when the person said, I totally believe this. I think really has to be your philosophy as a nephrologist, is I'd rather someone ready, try home dialysis and gain the quality of life and lifestyle benefits, who might be a little reluctant to from the start and really do well, and never have offered the therapy before, and for the person to remain really miserable and unwell in in-center hemodialysis. So everybody, I think, has and should have the opportunity to get educated about home dialysis and make an informed decision. And unfortunately, our patients who start on in-center hemo get the short end of the stick sometimes when it comes to modality education. And I think we have to really correct that. So we have to understand that this is a little bit of a challenging patient population and one that we have to spend some extra time and attention on. Next slide. The second is assess the readiness to change and engage the circle of care. I really loved Elias's red, yellow, green labeling of patients in terms of the risk and the willingness to convert to home dialysis. And to me, that's two parts. One is, are they ready? Are they motivated to go to home dialysis? And another part is, how likely are they to benefit from home dialysis? Do they work? Will it fit better into their lifestyle? I have some patients who would do fantastic on home because they work and they have busy families and they spend a lot of time in the in-center clinic, but they're just plagued with fear and plagued with fear of the unknown. And sometimes I think it's up to us to really support those people and give them a bit of a nudge. And it does take a nudge to change from something you're used to something that you're not. And I think it's really our responsibility to tell those patients how well supported they'll be. And this is a great example of an online virtual education session, actually, with the patients on in-center hemodialysis, the patient is monitoring. And what we've been finding in our clinic is that sometimes it's difficult to have these conversations in a busy, loud in-center unit. We've actually been doing virtual visits at home, even with in-center hemo patients. And this allows us to assess their readiness to change and also meet family members and friends. And I can't tell you how vital it is not only to educate the patient in the in-center hemo chair in front of you, but also their family. And sometimes with support and encouragement from family members, it can make a world of difference. They may not always be present during an in-center hemo session. Next slide. Facilitated transitional care model. So I have to tell you that the in-center hemo unit is a tough place to provide modality education. You know, you're sitting there in the waiting room, they may be hearing a lot of misinformation about home dialysis, and here you come starting to talk about home dialysis in the setting of an environment where patients may have heard things or may have seen things that may make them already have biases against home, which are very unfortunate. So what we try to do is start as many of our patients as possible within our transitional care unit for several reasons. One, it provides increased support and education for patients to think about a home therapy, and all of our patients meet and are intermingling with home dialysis patients in our transitional care model. And the other thing is, sometimes there are some challenges in getting a PD catheter to work or getting a patient converted from chemo to PD. And, you know, again, the eject button might be hit all too quickly in the context of an in-center chemo session. And so really with the support of being in a home dialysis environment, I think it really breeds a lot more motivation for patients to follow through and convert to home dialysis when there might be a lot of fear and anxiety in the background. Next slide. The other thing is to set an initial prescription considering lifestyle first. So that's true, as Juan does and as many of us do. We talk to our patients about the autonomy of home dialysis, the flexibility, the ability to do it from home. So it's very surprising to some patients when they're on a PD prescription that's extremely onerous from the start, that, you know, that can impact on their lifestyle. And, you know, on the left is what we worry about when we set a PD prescription. And rightfully so, we worry about these things. But we have to remember that patients worry about being able to sleep, maintaining employment, being able to look after their children. And I really think it's our responsibility to set as a PD prescription to help patients stay on PD that really puts lifestyle at the forefront of things. And because, again, there's nothing worse than putting somebody on home dialysis and saying, hey, well, you told me it was going to be a great lifestyle and I'll be able to do it at night. Only to have problem after problem that brings them right back to the in-center chemo unit. So we really have to work with our patients important priority. Next slide. So what are some of the things that you can do? Don't start with a lot of cycles on AP. The more cycles you do, the more opportunities there are for alarms. And this is a patient who's clearly not getting a good night's sleep. That doesn't mean you may not move some more cycles down the road, but the initial prescription as the patient and the PD catheter are getting to know each other, it's probably important to prescribe less rather than more cycles with tidal PD therapy. Next slide. Another thing is, again, incremental PD and using fewer cycles, less exchanges. The whole idea here in reinforcing this is that by less cycles, there's less opportunities for drain pain alarms, and the patient's first few weeks on PD will be hopefully more restful. Next slide. Another thing is how long to set patients on APD. This is, the horrible situation where people are dead waiting for their APD treatment to end. And the first thing I say to my patients is when you go to bed and when you wake up. And that sets the time on APD so that they really understand that you're working with them to try and make it fit into their lifestyle. Next slide. Other considerations are don't increase well volumes really quickly. Start very slow and make slow incremental changes, about 0.2 liters for the well volume increase. And I know a lot of our patients who convert from in-center to PD don't have a lot of residual kidney function, and certainly is moving in that direction. But make changes and make changes slowly and gradually. Tidal PD can help eliminate some of the drain pain with the catheter. And you can start with a day exchange in patients without residual kidney function, or you don't have to, but know that you're moving in that direction. And many patients who convert will ultimately need a daytime exchange. Next slide. But it's important to think about that daytime exchange. I'll show you that in a minute. And one of the things that we know is that patients who are exposed to in-center chemo or continue to get exposed to in-center chemo lose residual kidney function quicker than PD. And this is a paper from Jason that shows that hemodialysis is actually a very negative experience for the kidneys where there's lots of blood flow and decreased residual kidney function. So I always tell my patients, PD is not renal replacement therapy. That's a misnomer. PD is renal deficiency therapy, where chemo sort of overtakes your kidney function and may lead to a loss of residual kidney function. I always say to patients that PD, we're working with your residual kidney function, and we're adding to it as opposed to replacing it. So, again, that's a really strong argument with patients. The one point about avoiding blood, I think patients inherently also want to preserve their own kidney function as long as possible. And it's important to monitor it and respond to it with a day exchange. Next slide. Again, here are the options for the daytime. And the one thing you don't want to do, again, with this angry baby here in the middle, is you don't want to make people do lots of exchanges from the start. You have to gradually introduce PD. And again, isodextrin can be a really great strategy for the daytime to avoid a lot of those day exchanges. So again, the daytime exchange is a really important one for lifestyle. Have patients drive in the morning to go to the gym, give patients a period of dry time at nighttime to have dinner and be with their family. Again, lifestyle. Next slide. And then lastly, establish an open line of communication. I stopped calling Nina our modality educator, who's featured in the picture here. She's the transition therapy concierge. She is a psychoanalyst, she is a homemaker, she is a therapist, and it really is important for us to realize that people who start dialysis are scared. Their lives are never going to be the same. There's so much fear and anxiety, and I think a lot of the time, home dialysis is that next leap forward for patients, and it's really important for us to make our patients feel as supported as possible. And unfortunately, we probably don't do this enough, but I think with telemedicine and other strategies, there will be an evolving field of psychonephrology, and I really think it's important for us to check in with our patients, really have these important discussions about how things are going more frequently, and even bring peer mentors and peers into the discussion to help patients cope with some of the challenges of starting dialysis. And again, we know that a lot of these patients need fail because of burnout or for reasons that are not necessarily medical per se. PD would have medically worked, but more psychosocial reasons.
that so resonates with me. Fitting the dialysis into the life of the patient, as opposed to fitting the patient into our dialysis, right? Customizing the therapy, getting to know the patient well enough that you know what their needs are, and then trying to design any kind of dialysis, PD for example, to fit into their lifestyle. Because that's what I would want if it were me. It's what I would want if it were my kid or my mother. So why wouldn't we want to do that for our patients too? Thanks very much for that. So next slide. I'm going to do two things to finish this off. I wanted to show the audience how I think about patients and my process for assessing patients. And then I want to talk a little bit about the actual transition from in-center chemo to PD, because there's some, I think, places where we sometimes slip up that might be worth discussing. And so I want to share that I start off with the belief that most people could do PD if they had to. Okay? In my experience, the actual medical contraindications are really quite infrequent. And they're usually pretty obvious. A nursing home patient with a gastroscopy feeding tube, for instance, is not a good candidate to go to PD. The real medical contraindications are usually fairly obvious, in my opinion. But everybody else, I try to think about not so much the medical contraindications, but really how these different forms of therapy might either improve or make worse a given patient's quality of life. And from my point of view, we're able to offer 4 forms of dialysis, and I put on this chart my way of thinking about the various differences in the therapy. Because I think we ought to think about things like survival and hospitalization rate, and residual renal function, and travel requirements, and dietary burden, and all these other things. These are the things that really make or break the therapy. These are the things that make a person's life worth living or not worth living. And I think we should be thinking like this as we try to customize the options that we offer to patients. And, we might, you and I might disagree a little bit on some of this stuff, but I think I can make pretty good arguments from all the statements that I've made. So I'm not going to read this through to you, but what I would like to do is just illustrate 2 examples of cases where I use this kind of thinking to try to make decisions with the patient. So go to the next slide, please. And so here's an example of a 63-year-old man that's been on hemodialysis for 4 years. He's a functional fellow. He lives with and takes care of a disabled wife. He's done really well for the last 3 years. And now we go and we have a conversation about, is hemodialysis in-center really the best therapy for you? Should we consider switching you to another therapy? And so when I assess it, these are the kind of questions that I ask. Is he happy with the therapy? Is he doing well on it? Is he having side effects or problems associated with the therapy? We talk about things like fluid gains or diet. Are they problems? Is travel or work-related issues something that's relevant? How much residual renal function does he have? Are there not contraindications to PD, but possible concerns, medical concerns that might influence the decision? And then we think about psychosocial issues that might be an issue, and not just PD, but home chemo too. And then ultimately, what are this patient's primary goals, and are we achieving the patient's primary goals? And so go to the next slide. So for this example, when I interview the guy, he's perfectly happy with the therapy. He does get a little bit of side effects from the therapy. He gets some cramping, and he gets minor fatigue, mostly on Mondays. Because I really think that's an important question. How do you feel after you go home after dialysis? Some of your patients will tell you they can't do anything for 24 hours. In this particular man, he has some minor side effects, but not too much. We talk about fluid or diet. Are they issues? In this patient, his phosphorus runs a little higher. What about issues travel or work-related? He works part-time, but doesn't consider in-center chemo to be an impediment to that. In this case, he has no residual renal function. He has no medical concerns related to TB. And when we talk about the psychosocial thing, he actually likes coming to the clinic. He enjoys being there. He finds it to be a rewarding experience. And when I talk to him about what his primary goals are in his life, what he says is, I want to feel well, and I want to be able to take care of my wife. So go to the next slide. And so when I summarize these various issues for him, I say to myself, what's the quality of life? Well, it's actually pretty good. Would it be better on a different form of therapy? And I'm not really sure positive with you. What about survival? This guy, his 5-year survival prediction probability is actually really good. I believe that both center nocturnal and home hemo would probably improve his survival probability. PD, though, again, yours is 4 years in. I don't think we can argue that it would make it any better. It might be worse. What about symptoms and side effects? I actually think that other therapies might result in fewer side effects, but in this case, his side effects are already minimal. And the same thing would be true with diet, and the same thing would be true with fluid issues. And so ultimately, when I review this, he's pretty doggone content. His center nocturnal for him would be a problem because he needs to be home at night to take care of his wife. He really wouldn't want to do home hemo because he'd have no one to help him. PD would certainly be an option, but the conclusion at the bottom, I don't know that this guy would be agreeing. He can switch to PD in a heartbeat. That doesn't necessarily mean that he should, though. It doesn't necessarily mean that he would be better off or more fulfilled in his life if he switched. I think we might improve his survival. We might make his diet a little easier. We might improve side effects. But our decision, our joint decision, this patient and I, was that we were going to let him be alone. But we agreed that if in the future dialysis and access became a problem, or if actually spending 3.5 days a week at our clinic became a problem for him, then PD might be a really good choice, right? So this guy would be left alone, but reserve the consideration and might be a really good candidate to switch to PD sometime in the future. So let me show you my second example. This is a younger man, a diabetic fellow with some retinopathy. He's already wheelchair dependent. He landed on the hemodialysis clinic 11 weeks ago without any real planning, and things have not gone super well for him so far. I sit down and I talk to him, and I do the same sort of assessment that I showed you a moment ago. I ask these questions, and let me show responses in this case. Next slide. Is he happy and doing well? He says he is, but we've got him up to 4-hour and 15-minute treatments to try to control the fluid, and he argues pretty much every treatment that he wants shorter treatment time. And frankly, he's not tolerating that well because he's gaining 5-6 kilograms between treatments, cramps a lot. He's tolerating it okay, but I really do worry about the long-term harm that he's going to suffer as we try to pull all this fluid off in these short time periods, right? So fluid gains are a problem. We talk about travel or work. It turns out that's not an issue for him. He does have significant residual renal function. Are there medical concerns? Well, I don't consider diabetes to be an issue in terms of PD versus chemo, but some people would worry that his poorly controlled diabetes might be a concern. His psychosocial situation is that he lives with his parents. He has a lot of anxiety issues, okay? And when you ask him what his primary goals are, he says, I want to feel better and I want to stay out of the hospital. That's what he cares about. And so next slide, we do an assessment then. And as I try to compare therapies for him, I look at his quality of life, which I don't think is very good, and I think all the other forms of therapy have the potential to make his quality of life significantly better. Her survival odds, being a young type 1 diabetic, 5-year survival is not very good, to be very frank. I actually believe that all those other forms of therapy probably improve the survival statistics. When I think about symptoms and side effects, once again, I actually think that all those other forms of dialysis will probably result in fewer side effects to therapy. And likewise, diet and fluid, frankly, are probably better with the other forms of therapy. Now, his main issues, when you ask him what his main things are, is that the fluid, the diet, and the time tolerance. If he were to do instead of nocturnal, the big difference would be he would be sleeping in a clinic 3 nights a week. If he wanted to do home hemo, his parents would probably have to help him. And frankly, they might have to help him a little bit with PD also. So when we put this conclusion together, I say to myself, all forms of therapy would probably improve the way he feels and also his survival odds and lower his hospitalization rate. I think all would probably be better. PD in particular would probably preserve his residual renal function better than any other forms of therapy. And really, mid-center hemo has the very highest hospitalization rate. So any change, I think, would be an advantage to him. But when we really sort through it, what he decides he likes is the idea of dialyzing in his sleep, dialyzing at home, and not really requiring his parents' help. And so this is a guy that decided that he thought he might do PD, and we switched him over to PD, and he did really, really well with PD. So go to the next slide, patient. So that's the way I assess it, and I would encourage people to think about how they do these assessments and to try to be as intentional and organized in the process as you possibly can be. I'm showing you some orthopedic data because, about 2 years ago, we started looking at our ability to keep different populations of patients on peritoneal dialysis. And Jeff showed you a few moments ago a slide suggesting that there was a higher loss rate in people who started on in-center chemo versus people who started directly on PD. And unfortunately, we've seen that also in the DaVita universe. And in particular, we see the lowest retention rates in people who've been on hemodialysis for a long time who switch over. Now, some of the reasons might be that the patients are statistically older, they statistically have more comorbidities. As Jeff said, they're already used to in-center chemo, so going back, they already have fistulas most of the time, maybe going back is easy. But, I wonder if there might be some other reasons. And when we look at things like the training time, from the time they sign up for PD and they meet with the nurse and they get ready to start, to the time that they actually complete their training, what we learn is that it actually takes longer in these prevalent conversion patients, despite the fact that they ultimately average slightly fewer training days. And yet, we have twice the rate of 2-month losses. So we lose twice as many patients during that first 2 months. Now, I think Jeff explained it really well. I think that some of the problem is we don't really customize the PD when we transition them. We overwhelm them. And Juan did a great job of talking about setting expectations for patients. So I think that those are two really important things. The expectations that we set for patients and also for the actual prescriptions that we use to minimize the burden. But I also want to talk just a little bit about the actual training program for patients, because I actually believe that it might be in some cases that it's our training that always converts them that can be the problem. And so I want to give you some examples that I actually showed in PLS. So for those of you who are there, you've seen this before. Next slide. I think that when we do this training regimen, just like for the final prescription, we really want to think about how are we going to minimize the burden on the patient and their care partner. But also we have to think about our staff, too, our PD nurses and our PD program, right? Because believe me, it's a lot taking these patients over. We have to think about our clinic resources and maximize the efficiency of the process. And then ultimately we want to optimize our success with this, right? It's really demoralizing when you invest all this time and energy and the patient converts, and after 3 weeks they say, I don't think I want to do this anymore. So we've got to figure out ways to not make that happen. So next slide. And so what I started thinking about a lot is how can I use residual renal function to support the training process to help minimize the burden of therapy. And what this slide is intended to illustrate is that if you need to achieve a certain amount of small volume and fluid clearance to keep a patient safe during the training process, if they have no residual renal function at all, then we have to make all of that up with dialysis. Probably most of it with hemodialysis, okay, but maybe some with PD also. If they have a little bit of residual renal function, we should be able to leverage that as we train the patient. And if they have a lot of residual renal function, we definitely should be leveraging that when we train a patient. And so the first thing I would say to you is when you convert a patient, I really believe it's important that you measure residual renal function. Because you're not going to know how to customize the training process if you don't know how much residual renal function they have. So what we started doing in our clinics now, as we go through this conversion process, in fact, before they actually formally convert, is what I want to do now is measure residual renal function. And I also like to have the social worker go out to their home before we do the conversion. So we can try to anticipate some of these psychosocial issues that we might be running into. Because I think doing both of these improves our odds of success. So next slide. So let me illustrate a typical example for you of a patient who's been on hemodialysis for a while. The prescription that they follow is 3.5 hours 3 times a week. And this particular patient is anuric with no residual renal function. And now we're going to start treating them on PD. Remember, they have no residual renal function, so we have to ensure that we're going to get adequate small volume and fluid clearance to keep them safe. And what I think most clinics that I'm familiar with do, when they would keep this person on a Monday, Wednesday, Friday hemodialysis schedule. And then they would do PD training on Tuesdays and Thursdays. But I will tell you, when you talk to PD nurses, they will all tell you that this is really not an optimal training regimen. Because between Thursday and Tuesday, we're not really reinforcing this stuff adequately, and the patients forget things, and the process takes forever, and they just leave it. And the bottom line is, when I look at this, just like I showed you, the time until completion of the training process tends to be really long. And I think that's part of the reason why we lose the patient. And so I would offer to you that we ought to be thinking about how can we customize this training regimen. And the examples I give, for instance, would be to consider extending the time of dialysis to 4 hours or 4.5 hours, maybe thinking about doing it twice a week. And if you only do it twice a week, you can then do PD training 4 days a week. And while we do the PD training, we can also do some therapeutic PD exchanges and get some clearance in that way. And so there's lots of ways that you can do this. This is one example of a way you can do it, right? But rather than just sticking with the Monday, Wednesday, Friday hemodialysis prescription, I think if we customize it, we're going to be more successful. Go to the next slide, example number 2. And here's a patient who has a little bit of residual renal function. And again, one option would be to continue the Monday, Wednesday, Friday training regimen. But again, the other options would be to take advantage of that residual renal function, possibly reduce the frequency of the dialysis treatment, and increase the number of days that you do PD training. Now, what I think Dr. Pearl might tell you he would do is he might have this patient do PD training and PD treatments 5 days a week, right? In his transition of care unit, he's not in tech, so I think that's right. He would say, listen, with a little residual renal function, I feel comfortable stopping hemodialysis altogether. We'll have that patient in 2 exchanges a day of PD while we do their training. And that's going to really speed up the process, right? Now you're training them 5 days a week. Now you can't build the training and treatments on the same day, but that doesn't mean we can't do training and treatments on the same day. And to be clear, not every clinic would have the physical capacity to do this, because that means there's a patient in that room 5 days a week for 2 weeks taking up the space, right? But if you have the capacity, that might be a nice option. And let me just go to the third example. And again, as you might expect, this is a patient with lots of residual renal function. Arguably, this patient might have enough residual renal function that you can stop doing hemodialysis treatments altogether for 2 weeks. But that might not feel safe. And so maybe 1 chemo treatment per week would be enough just to make sure they don't get into trouble. And then you can have that patient come in 3 or 4 days a week, doing 1 or 2 therapeutic PD exchanges during every day of treating. And once again, to speed up the process. And frankly, in a patient like this, you can use, what we use is for a urgent start PD regimen to get that patient through the process. So all I'm really trying to illustrate is flexibility, trying to customize the training regimen based on the patient's needs and their residual renal function to see if we can make the training process more streamlined, less onerous, and ultimately more successful. Because I think customizing the training, customizing the prescription is really what gets those patients to the promised land. So next slide, please. And so, Dr. Pearl really talked about all these things. Customizing the training, customizing the therapy. The idea that we're going to drown everybody with dialysis is simply not necessary. There's no evidence in the world that getting a K2/V of 2.5 is any better than getting a K2/V of 2.0. So many of these patients have residual renal function, that customizing the prescription and being a little bit minimalistic so that we minimize the burden on the patient and the family, I really do believe is completely the key to success. We've got to do things like leverage diuretic therapy. We've got to monitor residual renal function and adequacy, because I will tell you, if we take a somewhat minimalistic approach to this, we've got to monitor more closely, because we're always going to be a little bit closer to the line, and you don't want your patients to cross the line. And the other thing, and this is so important to communicate to the patients too, is we've got to be prepared to make adjustments to the prescription to make sure that we keep the patient safe. But customizing therapy, we ought to be doing it on in-center chemo, we ought to be doing it on PD, we ought to be doing it in every form of modality that we have. But let's be clear, customizing in-center hemodialysis is really hard. Because as soon as that patient is done with their therapy, there's another patient waiting to take the chair. Customizing therapy in in-center hemo is hard. Customizing therapy at home dialysis is relatively easy. So, next slide. And with that, I just want to say it again. My goal in my patient care is to get every one of my patients onto that form of therapy which is best for that patient. And I want to fit my therapy into their life, not the other way around. And I do recognize that at different places in a person's life, different therapies might be more optimal. I sure don't want anybody to leave this webinar saying, oh yeah, they just want everybody to put on PD. They want us to convert everybody. That is not the goal. The goal is to convert patients who would benefit from converting. And with that, I'm going to conclude this part of the webinar. And if people have short personal anecdotes they want to share or questions that they want to offer, please follow the instructions on the slide. And we'll see if we can do a Q&A now.
And Dr. Shapiro, one addition, if you're dialed in just via the phone, you can't see the slide, but you can dial *6 to unmute your line and ask a question, and you can additionally chat your question in if you're dialed in via WebEx. So a couple of other options for you there.
Just so you know, there's nothing more humiliating for a panel of speakers than no questions at all. I'm just saying.
Once again, you can dial *6 to unmute your line, or you can click the microphone button next to your name. Now, I do have a question from Bill. This question is, about how many hours does it take to train a patient on PD?
How many hours? I'll take a stab at that one if you want to answer it too. We normally try to limit the training sessions to 4 hours a day because people really start to lose focus. And so if we average 8 training sessions for 4 hours, it ends up being somewhere in that 30-hour range. But I don't really know. I never thought about it in terms of hours. Somebody else want to try to answer that question differently?
This is Claude. Yeah, so we usually try to tell them the training sessions, especially if they're still in center, that will run around 2.5 hours, 4 hours. As you said, there is part of the patient who is very tired, and then something that is coming in, and that is the reason why we're trying to do it back to that, try to get them out as soon as possible for the training. But that is usually the time that we offer the patient when we're explaining the day-to-day life, that it is 2.5 hours to 30 hours mainly their training, and it could go around that time.
Thank you. Juan, do you have any opinions about training patients on PD on the same day that they need hemodialysis? Is there a proper order that's more successful?
I actually think that it just depends on the patient. There's quite a few patients, especially if they still have a lot of residual kidney function. And once they begin, they're willing to do both things. They're not ready to it. And many times, their goal is to get out of the center as soon as possible. So when we educate them, they're like, I want to get out. Not as I mentioned during the speech, that I just that many people like to say sometimes that they're going to be on training and just continuing out. Usually we're taking about a month of patients going back and forth and then some training and just educating. And they get really anxious. They're like, can I get out as soon as possible? So I feel that we get the option. Great majority of patients will be willing to train and go to the in-centers to get out as soon as they can from there.
Dr. Schleifer, my name is Martha. I am the dialysis supporter.
Yes, we can.
I think in our program, when we have these patients who are we don't do any HD during the during the 2 weeks that we use to train them. We just put them on the machine. Monday to Friday, and that's just the medical dialysis.
Right. So if your program has the ability to do that, and you're able to achieve enough dialysis, that would be great. Let me ask you a question. How many exchanges each day do you typically do while they're there?
Typically, we do between 3 and 4 days.
Okay.
There are admissions for about 6 hours during the day. On any given day, about 15 hours to 3 patients, one in the morning, a little bit of overlap, one in the afternoon.
And do you feel comfortable doing that in patients who have no residual renal function at all?
I would say to understand this is like start treating all of them. In center HD, if you think about it, there's really deliver all that much dialysis. You can deliver the same amount of dialysis by day, but it's much longer. It's not quite 30 hours of dialysis as against 1 hour.
Dr. Pearl, that's similar to what you do in your clinic, is that right?
Yeah, I think so. We do have to be a bit careful because we do need to make sure that patients have residual kidney function that will support them with TD alone in the early setting. And so I really like Mark's suggestion that we measure residual kidney function when patients come for training. That's certainly the first day of patient training in my program. A patient brings a 24-hour urine. And then we make that distinction. We decide, do we need to support with additional hemodialysis? How much do we need to support with? Or can we provide cycler-based dialysis at the same time as training? And so that patient almost becomes kind of like a surgeon start patient plus a training patient at the same time. And some days actually, to Watson's point, some people need time and small volumes of information to be able to retain it. So some days they're more training heavy focused. Some days patients just come in for 1 or 2 things and just do cycling for that day. So I agree with Mark that it's a great option, and there shouldn't be a hard and fast must-do hemodialysis during PD training for conversion, but it's very heavily dependent on how much residual kidney function patients have. And as Mark said, what the resources are of the clinic to support people. The other thing I'll say, and again, this is really a great model, is that we can actually use our whole hemodialysis equipment to support within our clinic the hemodialysis treatment, which makes it even that much easier to train patients.
I agree with you. Center. I try to support patients even 6 months of their treatment connection. Because by that time, a lot of them do have complicated children.
Right. And I think I don't know what Mark and Liz would say, but I think the earlier we convert, the better, in my opinion, for so many people.
Yeah. So I view it as a supplement to urgent start PD. We do a lot of urgent start PD in this community, which I actually think offers advantages above and beyond converting patients. Although we don't have really good data to exactly know how those differences are. But to my way of thinking, conversion from the clinic to incident patients is more of a complement to urgent start PD. But it is clear, the data are really clear about that loss of residual renal function, and not everybody experiences it, but probably a majority of patients do. Whereas, so interesting, on the PD patients, we often see an increase in residual renal function after they start therapy. And Joanne Bark has actually published on that, so that's something that we've seen quite a bit of too. I've got a couple questions in the queue that maybe I'll answer. One question is, I believe, yes, go ahead.
Sorry, Dr. Shapiro, this is Megan. I do have a couple of questions that we're just chatting to you privately. I did want to note whether or not on July 8th is about urgent starts. I am getting a lot of questions about urgent starts. So I did want to plug that. So for those of you who are in the queue, if we don't get to your questions in the time allotted, just know that you will certainly be able to ask it next week. And you can always email your questions to physicians@davita.com. But the one question that Brian sent to us is, are all units capable of doing urgent starts?
Well, I'll answer that. The answer is no. Unfortunately, we have quite a few one-room TB clinics with a part-time nurse because the number of patients is so small. And so you really do have to have a certain physical capacity to be able to do urgent start. And typically, we like to see at least 2 exam rooms and ideally 1.5 nurses to be able to do this because, if you've got one nurse who has a patient population to take care of, it's hard to do some of these things. So I think most clinics should be able to do it, and any clinic that has the ability to do it ought to figure out how to do it. But some clinics are simply too small to do it, in my opinion. Yeah, go ahead, please.
Our next question was again chatted to you privately. Where can my PD team and my nephrologist go to learn more about customizing PD prescriptions for training?
I'll try to answer that. I've never seen anything really published, and I've never seen anybody really speak about really customizing the training process. But I'd love to have a conversation with you on the phone or on the internet to discuss it because I think from my point of view, we're just starting to explore this a little bit. I don't know, Jeff, do you know of any resources for this particular subject?
Not in particular. Having said that, going out of this talk, I realized that there might be an opportunity to have a deeper dive into the training process and prescription consideration, in the new patient prescription, and how to make changes slowly and over time. So there are some resources out there, but certainly there's certainly an opportunity to build on those and provide more education on that. It's a great area.
Thank you both. I've got another question from John, and the question is, do you have any experience with overcoming issues with moderate to severe gastroparesis and CED?
Anybody want to start with that one? Okay. So gastroparesis is not necessarily more common in PD than hemo. You would think it would be, and there's mixed data on it. But certainly in my experience, I've seen it equally in the PD population and in the hemodialysis population. It can at times be more problematic for the PD patients, as you might imagine. And although I think everybody uses metoclopramide pretty commonly, I've also more and more begun using oral erythromycin at low doses, no more than 250 milligrams TID, which also is a pretty powerful prokinetic agent. And we've had a lot of success using erythromycin in patients for whom metoclopramide doesn't work or isn't well tolerated. Yeah. There's some old GI data looking at the types of solutions that you use and whether it affects gastric motility. I don't know that those studies were ever replicated. They're about 20 years old or 15 years old. And they did suggest that dextrose solutions might impair gastric motility as opposed to, say, icodextrin. But I don't know of any actual data that's ever really looked at the use of icodextrin to prevent gastric paresis.
Yeah. I would love to add to that and say, in general, in patients who are diabetic on dialysis, gastroparesis is a big problem. And I agree with Mark. I don't know if it's more common on PD versus chemo, but certainly because we're kind of doing things in the abdomen and people jump to the guns and the symptoms of gastroparesis are related to TB themselves. And so the first thing I would say is TB shouldn't really exacerbate gastroparesis more than HD, but it certainly makes people people think about their bowels and their GI tract that much more for whatever reason. So the other thing is, as I found, I think gastroparesis is a misnomer. I call it dysphoresis. And some people will have bouts of constipation followed by diarrhea, and it's very difficult to figure out if it's a hypermotility, a hypomotility problem, or both. And I find a lot of my patients struggle with both. So what I do is I say, if it's PD, let's try a night off and see if it actually made a difference. And 9 times out of 10 people say to me, my symptoms are the same whether I did PD that night or not, which tells me it's not a PD-related problem. And then at least, Mark alluded to erythromycin. We used to do a lot of IV erythromycin. But again, that's only going to work if the problem is constipation all the time. And it not always is. So we actually work a lot with 12 volumes, giving people lower 12 volumes, seeing if that makes a difference. And in the evening, giving people a dry period. Some people say that their appetite goes way up when they're dry, especially people with gastroparesis. So between 6 and 10 p.m., we sort of have a dry time where people can eat and have their largest meal of the day. But it's a difficult problem.
Thank you. I've got another question that was chatted to you privately. Anecdotally, do you see a correlation between ICHD patient compliance with medication and ICHD treatment and successful transition to home modalities? Are patients with poorer compliance generally less likely to transition effectively to home therapy?
I guess I'll start. I think it all depends on the reason for non-compliance. We have people that are non-compliant with hemodialysis because they really hate hemodialysis. They are afraid of needles, they're afraid of cramping, they're afraid of passing out, they're afraid of blood. They just don't feel well afterwards. They have sociological issues where they don't get along with people in the clinic, they're claustrophobic. I don't know that we always identify those issues very well. We just think of them as being non-compliant and difficult, and don't always really get to the core of why they're non-compliant and difficult. And with those kinds of reasons, I think many of those patients actually do much, much better on home. On the other hand, we have another category of patients who will never do anything you ask, no matter what you ask them to do. And it's not clear that those patients do that well at home. So I think there's no single answer. I think you have to really dig into the why of the noncompliance.
Thanks, Dr. Shapiro. Dr. Behran Nandaya, who said, do you have any thoughts about patients with ascites basically doing peritoneal dialysis? I don't have experience with that much experience. I'm curious about your life.
Jeff, you want to take that?
Yeah, we have a very strong use of PD in Toronto for what I call cardiorenal syndrome. Those people who are frequent flyers in and out of hospital, you bump up the diuretics, the renal function gets worse, and then you back off, and then the heart failure gets worse. And it can be a very difficult population to treat until you put a PD catheter in and start 1 to 2 exchanges. And then you're getting more optimal volume control and can dial up and down the PD as you need to. So I found that ascites that is of a cardiac nature respond exceptionally well to PD, with the caveat that you don't put in the catheter in the context of massive tense ascites, that you drain them. And I found that leads to a problem when people have ascites. And so we actually more frequently see patients post-PD catheter placement and use the catheter as a one-way drain day to day to just minimize the increases in intra-abdominal pressure and allow the catheter to heal. Now, ascites that's of a liver nature from cirrhosis, a little bit more difficult to tackle. If you look at reports from Korea and reports from Italy, they've had tremendous success with TD in patients with liver disease and ascites. I must say I haven't had a similar experience at my center in liver disease patients, but certainly if it's a cardiac nature or ascites, TD works wonderfully in my experience.
Well, I would agree 100% with that. The only thing I would add to it is that people with end-stage liver disease don't do very well no matter what kind of dialysis you put them on. But TD is problematic partly because getting that catheter to heal is is difficult. So you've got ascites, you've got low albumin, and getting that catheter to heal can be challenging.
I just want to say one very quick thing about the non-adherent patient. The non-adherent patient, what Mark said is absolutely correct. Those have been my most successful home candidates. I met a patient last week who was complaining about dialysis. The nurses don't put me on fast enough. The nurses don't take me off fast enough. I feel rushed during my treatment. And it was a list this long about all the issues with incentric chemo. And I've heard that time and time again. And I said, well, try home. You're your own boss on home dialysis. You set the time. You set the rules. You're clearly capable of doing this and intelligent. And, that patient is doing so well on home dialysis. So I actually think, I agree with Mark, you don't miss an opportunity in a patient who's, seemingly belligerent and disappointed with his center to reevaluate the role of home dialysis.
Thanks, Dr. Kroll. I've got a question. What would you say to an HD facility administrator that is pushing back on treatment and training on the same day because they will not get paid for any home dialysis treatment?
We have the unit operators on the line who would like to handle that question. So as a clinician, my answer would be you need to do what's best for the patient. And, I don't know that I would take that objection terribly seriously. But an operator might have a different answer.
I've learned so much from all of you in this presentation, but probably one of the most helpful concepts going away with is really to help them customize the amount of peritoneal dialysis based on people's residual renal function during their training. That's like a huge life in my religion. It applies to about 2 of my patients that just recently started. And I think the whole kind of minimalist approach is a very different approach than this. Because of all the KCD that we can get into. And I think having maybe Savita can put together all your wisdom in a little handbook, for the conversion handbook that could have all those things put in together in a 6-page document, just to give us more guidelines and ideas and print it out. I think all of us, who are new to this, new converters to this, we would appreciate it. And I think one of the obstacles is physicians' confidence in their own capacity. And if we can feel a little bit more empowered that we're learning something, doing things right, perhaps we'd be even more courageous and valiant as we try to get more patients on board.
They're listening.
Thanks, Dr. Elias. So we've got another question. What is the volume that you start with typically for a normal start and with the urgent start?
We typically use a weight-based algorithm. With the urgent start, recognizing that the catheter is not fully mature, we go with lower volumes. And frankly, DaVita's got a playbook that spells out those volumes based on body surface area. And so that's typically how we do it. And with the urgent start patients, it's low volume, through time, incremental over time. With a mature catheter, you can theoretically start with full volume exchanges. But, sometimes it's better to actually start with something lower than that because, again, you're trying to initiate the patient onto therapy. And the more gentle the process can be, the better it goes. Joanne Barton likes to say that nobody gets pregnant in a day because if they got 9 months pregnant one day, nobody would ever allow themselves to get pregnant, right? And so getting a little bit used to that belly, gradually getting bigger and filling up, I think is still a good strategy even for conventional start patients.
Thanks, Dr. Shapiro. We've got a couple more questions. Does anyone have any experience with a patient with drug addiction problem on home?
that's me again. Yes. And sometimes I knew it when I put them on the TV in particular, and more often I didn't realize it was an issue until after we had them on therapy for a while. And it could be a real management problem. You know, it makes people less reliable. It makes them less likely to have a home. You know, people who have serious drug addiction problems frequently end up being up and on the street. And so it can be a real challenge. I think the best advice I can give is to try to know about it before you start them on therapy as much as you can. Try to learn that, although sometimes it's hard to learn because people aren't very honest about these things. I don't know if I have any real good advice about it, though.
Yeah, I want to add an anecdote. I had a very well-to-do professional that had a drug addiction problem, and it was very difficult to uncover because they were so highly functioning, and you never see this person and think that they did have a drug addiction problem, but they did. So, you know, the first thing I would tell you is that it comes in all shapes and sizes and all different types of patients are maybe predisposed to a drug addiction problem. The other thing is that we would notice that they would skip dialysis, and that's actually how it came to fruition because through the remote monitoring, we could see that they weren't doing their dialysis sessions. It was really erratic. It didn't conform to a pattern. So a lot of people would say, oh, drug addiction, irresponsible, have to switch back to in-center chemo, can't do TD. But the repercussions of missing one TD treatment once a week or every other week are a lot less than missing that one chemo treatment after the long intracellular interval. You can imagine wait time. You really have to accomplish everything that happens in 2 days and 4 hours in terms of potassium removal and volume. So I would just caution anybody to say that the magic bullet answer to that is not necessarily to switch the patient in-center, but to get them the support they need no matter what the modality. So in-center is not necessarily going to, you know, overall improve the situation, in my opinion. Here.
Thanks to all of our panelists. I think we do need to wrap up. I would like to do a plug real quickly. If we didn't get to your question, I'm very sorry, but please email us your questions at physicians@davita.com, and we will ensure that Dr. Shapiro or another one of our panelists can answer that question for you. So if you're still waiting, my apologies. And Dr. Shapiro, I think, are you able to close up for us?
Well, yeah, I just want to say thank you to everybody for getting on and staying on. I really hope that this was helpful and instructive. I hope it generates a lot of thinking and a lot of consideration about how we do things in our clinics. And again, trying to be really patient-centric, doing the